and foremost, thank you all so much for joining us this evening for our very first virtual TIMS user group meeting. This evening, we are going to be talking about TIMS MVP 5.1 launch, which just happened last week. So we are super excited about that and sharing with you all the new updates in the software and the new innovations that will help us as speech language pathologists enhance our skills, elevate our care, and improve patient outcomes, which we're all passionate about. So here are our objectives for this evening. By the end of this course, our goal is that you will be able to apply the use of quantitative measures for MBS analysis, explain the benefits of comparing instrumental evaluations side by side with frame-by-frame analysis, summarize the benefits of software for reviewing and editing both MBS and fees, and describe the importance of archiving for PHI. And then here is our timeline and introduction. So my name is Brooke McGivern. I'm a practicing speech language pathologist and the director of marketing and communications here at TIMS Medical. And I'll hand it over to Tim to introduce himself.
I'm Tim Lazan. I am our director of product marketing and have been here for 11, 12 years or so now. Our
disclosures are just that Tim and I both receive a salary from TIMS Medical, and then I also am employed by the University of Iowa, Maryville University, and Mercy Medical Center, and we have no non-financial disclosures. So a couple of housekeeping items before we jump in. First and foremost, if you all are wanting ASHA CEUs similar to our TIMS University presentations, this is eligible for 0.1 ASHA CEUs, but you'll need to complete the survey. I will post the link in the chat as soon as Tim takes over the presentation, but it will also be sent out again via email from Zoom. So if you miss it, don't worry, it'll come via email. And you can also find it on our website on the TIMS University page under the heading for the TIMS users group. If you're wanting a certificate of completion, send me an email at tims-univ@tims.com and I can customize that for you. And then if you have any questions, feedback, or want to offer insight for collaboration, this event is extremely laid back. Like I said, it's not like our normal webinar style. We really created this with the intention of bringing people together that are using TIMS or are wanting to use TIMS to answer questions, get feedback, give ideas, all of those things. So feel free to pop any questions or thoughts you have in the chat, or during our open forum session at the end, feel free to unmute and turn on your video and talk to us live. Okay, so what is the goal of the TIMS user group? As I mentioned, our goal with this initiative is really to create a community of collaboration for both practicing speech language pathologists, researchers, educators, students, anyone who is using TIMS or is interested in utilizing TIMS. Our goal is to bring everyone together to create a collaborative environment. So our plan is to host these virtual sessions once a month, every month. We are planning to host them on the last Wednesday of every month, but some months will differ if there's a holiday. So our goals with this group are to have guest speakers to provide insight and expertise. We'll have open forum discussions, as well as opportunities to provide our team with feedback and ideas. Tim, I think somebody maybe is unmuted. And I do want to highlight the opportunities to provide our team with feedback and ideas. Over the years, we have had close collaborations with speech pathologists here in the United States and internationally. And I've been with TIMS for almost 2 years, but Tim Lazan, who's here with us this evening, as he mentioned, has been here a lot longer than me, so he can attest to that. But collaboration with speech language pathologists, both here in the States and abroad, has really brought a lot of the tools and features that you see in TIMS today. So that's why we want to have this open forum discussion. So if you have ideas or problems that you think TIMS can solve, we want to hear from you so that we can bring that back to our engineering and support team to see how we might be able to help solve those problems. And then of course, these sessions will, most of them will be offered for complimentary ASHA CEUs. Topics for 2024 and to 2025 include kinematic analysis, troubleshooting and FAQs, how we can harness TIMS MVP and TIMS Review to improve our patient outcomes. We conducted a national survey earlier this year that we want to dive into the results with you all in the future and talk about how Tim and I are wanting to help to work to make national change with those results. And then the history of TIMS Medical and SLP collaborative efforts, as I mentioned, as well as case studies about how people have advocated for TIMS in their practice, including a demonstration of ROI. So those are just some of the topics that Tim and I had brainstormed in creating this group together. And if you have ideas or thoughts on topics you'd like to see presented, let us know. You can email me at tims-univ@tims.com or send us a message on any social media platforms. Or if you're interested in being a guest speaker, please let us know, because we're also interested in having guest speakers. All right, so now we are going to dive into our content for this evening. So jumping right into the session, as you all are very well aware of being here with us this evening, instrumental evaluations are critical for what we do as speech-language pathologists. We are responsible for identifying the underlying causes of dysphagia, which highlights why we need both MBS and FEES, because we can't treat what we can't see. As we all know from current research, both the MBS and FEES are considered gold standard options for instrumental evaluations, and some patients benefit even from having both studies. So why are instrumental evaluations so important? Again, this is no news to anyone here this evening, but we know that both the MBS and FEES are critical in identifying the underlying pathophysiology resulting in dysphagia. Further, instrumental evaluations help us determine patients' issues with safety and efficiency and create individualized care plans. Without instrumental evaluations, we run the risk of over or under prescribing interventions, or doing things such as modifying diets and providing thickened liquids. We can also avoid increased healthcare costs and increased costs to the patient when we utilize instrumental evaluations. And of course, we know that the use of both MBS and FEES allows us to create tailored, individualized treatment plans for our patients, which of course improves their outcomes, saves them money, and helps them reach their goals, and does so in a way that's evidence-based, which we are all passionate about. So why is software important? There we go. Okay. Sorry, getting distracted by the audio. Okay, so why is software important for both the MBS and FEES? And I don't know about you all, but software wasn't something I always thought about until recent years, but especially with new innovations in software, we can really see how we're able to harness innovations and updates in software to advance our clinical practice through some of these points that I will talk about on this slide. Number one, I think one of the most critical things that software helps us do is improve interdisciplinary collaboration. We know that through the use of software, we can increase the team's access to imagery for both MBS and FEES, which is really critical when we are trying to make individualized care plans and incorporating everyone in the team to determine best next steps. Second is decreasing the risk of HIPAA violations. I don't know about anyone else on this call, but in my own clinical practice, I have previously had to utilize removable media such as USB drives, specifically for FEES performance, because I was not able to upload my FEES studies to PACS or VNA, or incorporate any snapshots or anything like that in my reports, which again, as you all can attest, a picture often speaks 1,000 words. We can describe all we want,
look
but
again.
Sometimes it's really nice to add that picture into what we are describing in our documentation. So we can utilize software not only for enhancing our reports and that interdisciplinary collaboration, but also reducing the risk of HIPAA violations from removable media such as USB drives. Additionally, here at TIMS, we have worked with over 6,000 healthcare teams across the United States and abroad. So we've seen pretty much everything, and Tim can attest to this, anything from USB drives to DVDs and even VHS tapes. So slowly but surely, people are really updating their tools and techniques to reduce the risk of HIPAA violations that can occur with that removable media. And of course, both of those things that I just mentioned, increasing the interdisciplinary collaboration and increasing both team and patient access to their information through archiving processes, help us to improve patient outcomes. But not only does archiving help patient outcomes, we know that standardized analysis methods, such as some of the techniques and methods that we're going to talk about this evening, help us to better improve our recommendations when we are performing both FEES and MBS. Additionally, things such as quantitative measures can be more easily implemented when we are utilizing software in our practice. And then other things that, are a little bit more commonplace, but we haven't always had, such as frame-by-frame analysis, slow motion review, synced video and audio, etc. All of those things are really critical when we are thinking about our analysis process. We know that swallowing is very complex, so these tools can really be harnessed to help us maximize our abilities to provide those tailored treatment plans. And then, as I mentioned, when we are able to archive these studies, we increase our patient access to their pertinent health information. Just earlier this year, Tim and I did a presentation in which patients were present on the call, patients that had dysphagia. And at the end of the presentation, we had a couple of people in the audience ask, how do I determine if the hospital that I'm going to for dysphagia therapy has TIMS MVP, because I'm really wanting to access my MBS and FEES records. These patients in particular were people who had long-term dysphagia. So they were really interested in seeing their FEES and MBS imagery. So it just, I think, speaks to the patient's motivation and desire to have access to their medical records and the ease at which we can help them obtain that through software. Additionally, software helps us to streamline workflow processes. So that is, we'll talk about that here in a little bit about how we do that at TIMS, but thinking about ways in which we can increase efficiency, but also at the same time improving our use of standardized tools and the implementation of quantitative measures, which we know is in alignment with the current research. So how does TIMS MVP support these objectives? Again, if you're on this call this evening, you most likely are probably already utilizing TIMS, or you're interested in utilizing TIMS, which is why you're here. So number one, of course, we know that TIMS allows us to record, review, assess, and edit our studies. So in my own clinical practice, I'm now fortunate to have TIMS for both MBS and FEES, and can attest to this improvement in workflow and efficiency. I'm able to do either study, FEES or MBS, on my cart, and then send the study back to the speech language pathology office. So that frees up our equipment so that more patients can be seen in a day, but then I can also go back to the speech office and utilize some of these analytical tools that we've been discussing so far, and we'll discuss farther in depth. So that's one of the big pros of having TIMS MVP. But additionally, as I mentioned, those standardized tools and the quantitative measures that we're going to dive into here in a couple of minutes, I'm also able to utilize those in my TIMS review software. So this, of course, helps me on the analysis side, and then I can send that information over to our PACs so that members of the interdisciplinary team can see it, and I can utilize that imagery to support what I'm saying in my report as well as my recommendations. So I'm reducing those HIPAA risks, and then I'm also able to utilize that information across the enterprise to communicate with different team members. Just earlier this year, we had a case. It was a patient that was referred to us for dysphagia complaints. It was in acute care, and long story short, we performed a FEES on this patient and saw a concerning mass, and we were able to, because of TIMS, upload that imagery in the report immediately and send it over to ENT and get a stat ENT consult in. And they didn't have to rely just on my descriptive documentation. They were actually able to see the imagery that I was able to obtain from our fee scope and then upload via TIMS. So it really helps us improve that interdisciplinary collaboration in real time quickly. And then, of course, improves our ability to empower our patients to make informed decisions about their care. So I did include a link here. If you're interested in learning more about patient access to records in terms of ethical concerns, legality, etc., this link here that's called out is from the U.S. Department of Health and Human Services. This is a topic that I think is really important for us as speech language pathologists to be aware of and to help us advocate for tools and resources to help us empower our patients. So if you're interested in any of these slides, reach out to me and I can send them to you, and this link is hyperlinked there. All right, so diving into some tools and features to help support our clinical practice. The first couple of features that I'm going to discuss are slow motion, frame-by-frame analysis, and study comparison. So both the MBS and FEES guidelines recommend both slow motion and frame by frame analysis. Again, as we all know, swallowing is extremely complex, and the accuracy of our interpretation may be negatively impacted when frame by frame analysis and slow motion are not available. So both of these tools are available in TIMS. These are not new. If you have TIMS, you know that you can do this. And we did have study comparison in TIMS MVP 5.0, but as you will see later from a demonstration from Tim, we now have additional ways that you can compare your studies. So you can now compare two trials within the same study side by side, frame by frame in TIMS MVP 5.1, which is really nice. So this is just another way to elevate our care and compare studies, whether it be two studies, both an MBS and a FEES for the same patient, or maybe they did, their baseline fees and then a follow-up fees that you want to compare, or inter-study comparison. So additional tools that have been requested by clinicians and researchers just like us. Additionally, synchronized video and audio. So, these things may sound like commonplace that everyone has them, but again, I don't know about anyone else on this call, but I definitely have performed MBS where, we're needing to use magnets because our MBS and radiology suite are not equipped to record audio. Additionally, if you are conducting a FEES where you don't have synchronized video and audio, maybe you're needing to pause in between each trial so you can go into your software and type what the trial was that you administered. So it's really important and beneficial when we have synchronized video and audio because they allow us as SLPs to review and analyze events that occurred during the instrumental evaluation, including what trials were administered, education and instruction that we provide to the patient, as well as patient feedback. So of course, TIMS provides this as well. So what tools are in TIMS? Again, if you haven't seen this already, these are all tools backed by evidence that are already in TIMS to help us in our MBS and FEES analysis. So you'll see here on the screen the list of the currently provided tools for both MBS and FEES analysis. We have the MBS IMP, Digest, Digest FEES, Voice, E10, Penetration Aspiration Scale, New Zealand, Reflux Finding Score, Reflux Index, and the Yale Pharyngeal Residue Severity Rating Scale. I will also note that the rest, which is an esophageal screen, is coming soon in TIMS. So, these are all in TIMS already, and we've input these into the software to help improve clinician access to these tools and resources, not only because of their benefits, but also to help improve consistency within the team. So I did want to go ahead and show a resource that we recently created. I'm going to click here. Tim, let me know if you can't see this. So this is an analysis method section on our website. So if you haven't seen this already, this is available on our website right now. But if you scroll down, we have all of the analysis methods that are in TIMS listed on our website with a description of what it is, as well as opportunities to learn more. So some of these tools do not require any type of certification. Some of them just have open access resources, and some of them do require certification, but you can check those out here. And then at the bottom of the screen is where we are including all of the tools that we will be inputting into the software in coming months and years. With that, I'm going to click back to my presentation. Tim, are you back in my presentation with me?
Yes, ma'am.
Okay, awesome. And then the last thing I will mention before we move on from this slide is if you have requests for analysis methods that you'd like to see in TIMS, shoot us an email or send us a message on social media because we're always happy to take requests. Okay, so now we're going to dive into quantitative measures. So why quantitative measures? This quote is from Carrison et al. In 2023, which says that quantitative measures in MBS analysis improves the accuracy of identifying swallowing impairments, as well as improved and more targeted treatment recommendations when compared to traditional analysis alone. So basically, we know from current research from the work of Carrison et al., as well as other researchers, that when we add quantitative measures, it helps us elevate our analysis compared to just our standard analysis that we typically conduct. So what objective measures can you perform using TIMS? This list here on the screen is not exhaustive, but it's a list that I came up with when prepping for this presentation, but also when creating a document with step-by-step instructions for how to perform different quantitative measures. So if you have other ones that you're using in your clinical practice, please pop them in the chat so we can see what you all are doing. But these are just some objective measures that you can perform using TIMS right now. So I'm going to go through a few of these, not all of them, or else we'd be here for a few hours, and I don't want to take up too much of your time. But quantitative measures that we will go through this evening are anatomical measurements, the bullous clearance ratio, or BCR, the maximum width of UES opening, duration of UES opening, and bullous percentages. So example one is internal anatomical changes. So this photo was provided by Jessica Greger. If you are familiar with Jessica, she is a specialist in dysphagia at the Mayo Clinic in Phoenix, Arizona, and she works frequently with people with head and neck cancer. So these photos are a demonstration of her utilizing TIMS MVP to analyze internal anatomical changes that have occurred secondary to radiation therapy over time. So she's using the line tool here to demonstrate those changes from pre-radiation therapy to post-radiation therapy. If you are interested in learning more about how she's doing this and the work that she's doing, she provided a webinar for us through TIMS University earlier this year, and you can access the replay for that on our website. And she does review how she is utilizing this line tool in her own practice. Speaking from my own personal experience, I have also used this tool similarly to demonstrate the benefits of manual lymphatic drainage for people with head and neck cancer that are being seen in the outpatient setting. So this is just one example of how you could utilize this tool. Other thoughts that have come to mind and that I know other colleagues and friends are utilizing this tool for are things such as ACDF, changes post ACDF. So just another tool that you can utilize to demonstrate internal anatomical changes over time. And then with that compare feature that I mentioned earlier, as you can see, this is just a screenshot hooked together, but you could actually compare your study side by side. So let's say you have a patient who you're seeing for an MBS immediately following an ACDF, you could compare that study here on the left and then compare their follow-up study on the right-hand side, which is really nice. The next measurement that we're going to go through is the bullous clearance ratio. So Leonard in 2017 discusses that the bullous clearance ratio is a measure that assesses material in the pharynx before UES opening compared to material in the pharynx after the UES closes. So you can see here, I've got some screenshots just demonstrating how you conduct this measure in TIMS, but you're going to outline the bullous in the pharynx using, in this case, I used the freehand tool because I wanted to try to be as accurate as I could in outlining every little detail. But you're going to outline the bullous in the pharynx with whatever tool you prefer, freehand, magic wand, or magic brush before the US opens. And then you're going to set the number in pixels to 100. So you can see here that I've got this labeled as pre-UES 100. So what you would do, and again, when Tim does the demonstration, you'll be able to see this a little bit more clearly, but you're going to outline your bullous, and then you're going to come up here to your measurement tool, which is actually will be up here in the right-hand corner of your TIMS, but you'll set the percentage to 100, and then you'll close out of this. And then, like I mentioned earlier, the importance of frame-by-frame analysis, you'll scrub forward in your study, and you're going to outline the amount of the bolus after the swallow has concluded, and TIMS will then give you the percentage compared to the original bolus. So this is a patient that I was seeing who had significant safety and efficiency issues post head and neck cancer. So he had quite a bit of pharyngeal residue, as you can see. So he actually ended up having 67.79% of the bolus remaining behind in the pharynx post swallow. So it's really nice to utilize TIMS for this measure because it does the calculations for you. And we do have posts specifically on bullous clearance ratio on our social media platforms. So if you're interested in utilizing this in TIMS tomorrow, but you forget how to do it, you can definitely find those posts on social media. And if you don't have TIMS, but you're on this call this evening, you can also conduct BCR and ImageJ, and we do provide those instructions on our social media platform as well. So the next measure that we're going to go through is the maximum width of UES opening. So this is measured at the narrowest point between C4 and C6 during the swallow. And if you haven't seen it before, there is a great article that describes this and the next measure that we'll talk about by Kim in 2009. So if you are working with a patient that's having UES dysfunction, and you're wanting to just assess maximum width opening of UES over time, this is a great and easy measure that you can add into your clinical practice to demonstrate improvements or changes over time. The next measure that we'll talk about is the duration of the UES opening. So this is measured from the moment that the UES opens until the moment that the UES closes. And to learn more about this, you can check out articles from Robbins et al. 1992 and Logeman 2000 and 2002. So I've got some screenshots here showing how to do this. I'm going to zoom in so you can see. So in this first screenshot, this is just a still shot of the MBS. But when I go to the second screenshot, I'm going to zoom in. Hopefully y'all can still see this. You're going to click on this turn on timing mode, this little timer down here in the bottom right-hand corner. And then you're able to time, you could time whatever you wanted with that timing tool. But in this case, I was measuring the duration of UES opening. And you can see here that on my timeline, there's a little white out line here. That is indicative of the duration that the UES was open. And this is telling me how long it was open for here in the right-hand corner. So we sometimes get questions about what delta means. Delta simply means difference. So again, that's just another measure that we can incorporate into our clinical practice and compare over time to demonstrate progress and prognosis. The next measure that you may have seen us talk about on social media is bolus percentages. So this is just a really simple method of analyzing a given bolus. It's similar to BCR, other than the fact that you can actually utilize this to measure oral or pharyngeal or oropharyngeal residue. So similar to BCR, what you're going to do is outline the entire bolus prior to UES opening. And again, you'll set that to 100%. And then you'll use frame-by-frame analysis. You're going to scrub forward to post-swallow after the UES has closed, and you'll outline the material that you wish to measure. So this could be, like I mentioned, oral or pharyngeal residue or even aspirated material. So I'm going to go ahead and zoom in. As I mentioned earlier, TIMS does provide you with the percentage, comparing it to the original bolus. So if you set your original bolus to 100%, TIMS is going to tell you what the percentage is of your residue. So you can see in this patient's case, as in a lot of our patients, the residue wasn't cohesive. So I actually used a freehand tool to make two different outlines and then just added them together. So the example shown here is 62.36% of the original bolus remains. I have also utilized this tool in my own clinical practice to discuss the percentage of material that was aspirated compared to the original bolus. So you can use that in a variety of cases. The case that comes to mind for me this evening is one in which a patient aspirated, but it was a very small amount. It was 2% of the original bolus on one trial. So it was actually kind of cool because I had a nurse call me and say, I'm confused why you recommended this patient a diet. I saw in your report that he aspirated, and I was able to tell her the exact percentage of aspiration that occurred over the course of the whole study. So it's kind of, I think, a really fun and easy tool to utilize. And you can even put in these screenshots like I've done here into your report to further demonstrate what happened in the study, which can be really beneficial for the interdisciplinary team. Okay, so we've talked a lot about MBS, but what about fees? So we recommend that if you haven't already, that you check out the visual analysis of swallowing efficiency and safety, which is VASES, developed by Dr. James Curtis. VASES aims to increase transparency, sensitivity, reliability, and generalizability. VASES is a standardized approach which provides ratings for pharyngeal residue penetration and aspiration during fees, and it also establishes clearly defined anatomic and temporal boundaries. So VASES is currently not in TIMS, but we are working with Dr. Curtis on what that could look like in the future. But in the interim, you can actually use the notes and report templates in TIMS MVP to adapt them for VASES from examples on Dr. Curtis's website. So one of the teams that I work on clinically, we have actually been utilizing portions of BASES in our own fees program and are looking at adopting BASES into reports and note templates. So it's really easy to do within the TIMS software. And again, it's going to help us promote that consistency within our team for how we are performing fees analysis as well as reporting. So again, this is something that we recommend here at TIMS. And if you are interested in learning more about BASES, Dr. Curtis did provide us with a webinar for TIMS University earlier this year, which you can check out on our website. And he has a plethora of resources on his website, including those templates that I mentioned. Okay, so we are almost wrapping up my portion of the session so that Tim can dive into new features in 5.1. But kind of wrapping this up, standards and reporting. Again, we can all attest to how important documentation is. As SLPs, we take on a huge responsibility in documenting not only for the SLP team and the interdisciplinary team, but also for the patient and the insurance companies. So at TIMS, we've really tried to make reporting as easy and efficient as possible while not losing any sort of standards or evidence-based practice. So we have semi-automated reporting, which I know Tim is going to discuss a little bit more in his demonstration, but everything that I just showed you, all of those measures, the scoring mechanisms, the snapshots, all of that can actually be semi-automated into your report. So what I mean by that is as you are working through all of the things that I just discussed, they pull through and populate into report templates within TIMS. So that way, when you go to open your report, you should be about 80% of the way done with your report. It makes our analysis and reporting almost succinct so that we're not doing twice the work. So with that, we do have report templates that come with TIMS. We are also working on creating a tool where any clinicians that are using TIMS can actually go to our website and download different report templates specific for different patient populations and settings, but you can also customize and create these reports yourself for your team needs. Further, we have smart phrases similar to EMR systems out there, and that is applicable in our notes and reporting section. And then I already talked about the integration with our scorecards and snapshots, but I did want to mention that you can actually integrate your reports now with your EMR. So you can actually do everything in TIMS now, all of your analysis, which flows through your report, and then pop that report right into your EMR so that you are saving time, which we all know is very, very precious in the clinical world. So last but not least, we really are just striving to increase access across the team, not only within the interdisciplinary team, but within the speech language pathology community, which is why we are hosting these meetings to share best practices. And I want to conclude my section with just highlighting the importance of industry and clinical partnership. As I mentioned at the beginning of this presentation, many of the features and tools you see in TIMS today have come from collaboration with speech language pathologists, both practicing clinically and conducting research and teaching. So if you have any thoughts, ideas, or problems that you think that we at TIMS could help solve, we would love to hear from you. So with that, Tim is going to dive into all of the brand new features in TIMS MVP 5.1. So Tim, I'll hand it over to you.
Thanks, Brooke. Very nicely done. Thank you so much for all of that great information. Let's see, let me share my screen. Thank you. And let's shoot it over to here. Okay, so I'm going to be walking through some of the new features here in TIMS MVP version 5.1. And I'll ask a few questions as I go along. I think you have a way of giving like a thumbs up and stuff like that if it's a yes. So with that, let's get rocking and rolling here. The first new feature is something that's been requested for some time. So let me, I'm going to pop open, let's make a new study here. We'll make a new fees study. And it's a pretty basic feature, but a pretty nice feature. I think especially lends itself well when you're doing fee studies and you're guiding an endoscope through someone's nasal cavity and things like that. So, and I'm sure your patients will appreciate that. You want to get the best view possible. So now when you hit the F10 key, so we're in a FEES study right here, and it's live. If I hit F10, now I fill the entire screen with the live video, so you don't have a smaller image to be looking at. You'll be able to get a really great view of all the action as you're doing that. So, and then you can hit F10 again, and it'll shrink it back down. Or if I'm F10, you can hit Escape, and it will size it back down again. So again, pretty basic, but it's been asked for quite some time, and we're listening. So we wanted to. That's now available in 5.1. And by the way, 5.1 is available for download right now. So if you have an active support contract, you can contact our support department, and they will help you get TIMS MVP 5.1 installed on either your TIMS system or your TIMS review software. So let's look at a couple other things. I'm going to close this guy out here. And I'm actually going to go ahead and delete that study. I don't need that one any longer. I have a couple of other studies queued up here. I'm just going to go ahead and open up this middle one right here and go into series mode. Should look pretty familiar to everybody. So I've got an MBS study queued up, and we've had, and some of these features, honestly, I bet a bunch of people, some of these things have actually been in the software for a little while. I'll call out the 5.1 specific things, but there may be some of these things that you just haven't been exposed to or haven't seen yet. So I'm going to be focusing on the compare function, which you can see top left center of the screen here. If I click on compare, I'm looking at two studies side by side right now. And so this left-hand one here is my current study. And you can see if you click on this, you can pick which series you'd like to be viewing in this guy here. And I'm actually going to go ahead and say, yeah, I'll stick with that. And then on the right-hand screen, and you'll see I have a date pop-up menu here. And it shows me that I can either view, and one of the new things in 5.1 is you can view side by side in the current study versus I have some other studies here from that same patient. So it automatically finds any other studies by that or for that patient that are resident on your TIMS system or on your TIMS review system. So I'm going to go ahead and select a previous study. So the patient may have come in, 6 months ago, and they're back for a revisit. And now again, over here on the right-hand side, you can see I have fewer series available to me. That was the earlier study, and I can select this one here. And what's fabulous about this is I can scrub through these independently. And I'm just clicking right on the image and moving back and forth. So we call that scrubbing. Or so I can do either one of these guys like this. And you can go frame by frame for either one of these as well. And so we've had that in the software for a while now, but you can also now play them simultaneously and control them both with this center play control right here. And you can go backwards and forwards frame by frame. And what's kind of fun about this is you can see they're somewhat out of sync here. I'm looking at let's say a thin liquid swallow here. I can independently rewind this guy till, maybe right before they're about to swallow. And I can find that same spot. Let me rewind to here and get to a similar location here. And now when I move through them frame by frame, I can be looking at, any improvements maybe they've made through therapy and whatever you've been working on with them, and see how things are differing from, whether it's just the oral phase or, any component that you wish. And you can, again, sort of slide these back and forth to get the timing right and watch them in full motion as well. It's really mostly kind of interesting when you can go frame by frame. I think you can really see specifically what's going on between the two. So that's kind of fun like that. And I am going to, not only does it work for MBS studies, but we do have some of our customers that are doing simultaneous fees and MBS. They're actually performing both the studies at the same time. It's not super common, but you can do the same thing here and be looking at, you know, a fees view or an endoscopic view at the same time that you're looking at a fluoroscopic view. So that's pretty amazing. So really, any studies you have available for that patient, you can pop up right here. The other thing that's nice about this, let me go back to this other previous study here, and I'll find. Sorry, I keep moving around my. There we go. I'm going to select again the same series here, and let me just unlock my study, and I might find here something very interesting between these two at around the same phase. I have this little camera icon right here, and I can take a snapshot of this and call this an interesting find here, and it will put that when I go back to my series view here and move to the top left. You can see that compare is actually a side-by-side snapshot that is in. It will be a part of the study as well. So that will travel to your PACS VNA as a component of the study, and you can click on this and annotate it if you wanted to, and point out certain things for other viewers and, you know, other colleagues and things like that. So it's an image just like any other snapshot that you might take with your TIMS system. So that's compare and some of the enhancements to the compare feature. Let's go on to another feature that again, I'm not sure if you're able to click sort of a thumbs up. I'd be interested in seeing how many people are using the notes feature in TIMS. Yeah, I guess I'm not seeing that here, but everybody's responses. But well, let's take a look at notes. So in the top center here, I have a notes tab. And these notes are template based. And so you can create any number of templates that you want. I've created this one called TIMS Users Group. And you just go ahead. It's like going into a word processor or an editor, and you lay out what you want for a template, what kind of information you'd like to capture on either an overall study basis. So I can put in some observations for this study here. And that will be, you know, that's just for the study as a whole. But you see I have a series tab here as well. And if I click on that, I am taking notes specifically for this series. And here are some of the pop-up menus that you can create as well. If I go, let's see, I'll show you. You can actually even, this one won't make sense, but I can click, do multi-select as well. And so that's, in fact, not only can you do series, but if I have snapshots, then I can take notes on snapshot and create a template for that, and even on my compares too. So, but I want to go back to here on this first one, and for here I made room for another new feature that we have, which is the ability to paste measurements that you've made, and similar to what Brooke was showing a few minutes ago. So I'm going to, let's see, scrub along here. And let's do a little hyoid excursion measurement. So I'm going to find my hyoid basically at rest here, and then pop open my tools menu over here, grab my linear measurement bar, And I'm going to do a C2 to C4. There's a number of protocols that are starting to use relationships between the distance C2 to C4 and some other measurement, and then compare that against some normative data that you might have. So let's do that. And then I'm going to hit my little ruler up here in the top right. And another new feature we have is the ability with these labels to have them predefined. So if you're doing this a lot, I only have to type C2 and I've got my C2 to C4 measurement there. And now I'm going to make another measurement and follow my hyoid to its max. So I'm going to draw a line where I think it might be landing roughly, and I'm going to use my arrow keys and get to hyoid max here, and that's about right there. One of the tools you can use is the ability to reposition an endpoint on my line tool here. So I'm going to find that same point on the hyoid that I had before. And so that's, whereas, whoops, I wanted to set this, forgot to set this to 100. And I'm going to call this excursion, which I also have sort of predefined here. And now you can see this is 38%. This line I just drew here is 38% of my C2 to C4 measurement. And again, you can use that to compare against normative data. And if I click this down, it's also giving me my superior and anterior measurements as well. And now this whole table right here that I've created, all my measurements, if I come up to the edit menu, top left corner, we have a new menu option called copy measurements. And so let's copy that. And there we go. For some reason, right click wasn't working, but my control V for paste works. So I'll put that here. And you can see you get a nice table with my C2 to C4 and then my relative values compared to that. And additionally, so we can paste our measurements tables. And Brooke was showing you earlier how to do temporal measurements. And I'm not going to do anything fancy here, but I am going to just click somewhere. And one way to quickly measure time is just to right click and hold down on, I'm down on my timeline here, click and hold, right click and hold down, and you can see it's leaving a white trail behind here showing the area that I have, I'm measuring time wise. And then I get my delta here and I can click on it and paste that in as well. Wow, everything's misbehaving here for me. It's just the demo gods sometimes frown upon you at times. Point. There we go. So I've pasted in my my 1.233 seconds time measurement. So that's some of the new features and notes. Oh, the other thing we did in notes too as well is the ability.
Can I interrupt you for 1 second?
Yes.
Just for anyone who doesn't know why you would use notes, the whole idea behind notes is that you can have this popped up kind of like a sticky note or a notebook while you're performing your analysis. And then as I mentioned earlier, all of our reports are semi-automated. So Tim will show you this, but once you open up your report tab, everything that he just put into notes, so his hyoid measurements and his timing measures, that will all be auto-populated into the report. And then any screenshots, scorecards, any of that will be populated over into his report. And Tim, there's also a request if you could show where the draw features are. And then Julie asked about how to set it to pixels. Everything it's automatically set in pixels, Julie. Like if you're drawing a line or anything like that, it starts out in pixels. But yeah, Tim, if you want to show some of like the draw features.
Yeah, let's take a quick look at those. So they're all under this menu right here, which is my annotation menu to turn on the annotation tools. And of course you can set what color you'd like to use, as well as line thickness, and I like the thin line here. And then right above that, I've got the different types of tools. So I'm going to start with some of the fancier ones, which is my magic wand tool. This is great if you have a bolus like this, that it's all pretty well together in one place. I can click anywhere in here and just start to pull out away from it, and it's going to auto select that based on tolerances, and auto select the bolus for me. So I can do that in any area. If I had, let's just pretend this was residue, small residue amount or something like that. So that's magic wand tool. There's the magic brush tool, which is somewhat similar but a little bit different. And here I just start pushing my cursor around the area that I'd like it to outline automatically for me, and it will do it just like so. All right, so that's a magic brush. So they work a little bit differently. And let's delete that. Then I also have my freehand tool as well, which you can just sort of freehand draw. And like so. So those are the primary tools for outlining something. And again, you're getting it in pixels. So, and I'm not sure we have the time to sort of go into this right now, but you're either doing things as measurements, one measurement relative to another measurement, or if you have a way of calibrating to a known value, like millimeters or something like that. People have used a penny taped to a neck. There are other ways to do it. Something that the size of, you can measure that first, and then say that's 19.33 millimeters, and then any measurements you make subsequent to that will be in that same millimeter measurement. All right. So that's some of the notes, pasting measurements, pasting time. Let's look at some of the other things we've added to reporting as well. So I'm going to go up and open up my report menu. And again, I'm sort of guessing maybe a lot of people aren't using reporting yet. It's been out for a while, but these things take a little while to have everybody adopt them. So when I pop open my report, we talk about it sort of semi-automatically populating a lot of the report for you. So I'm going to start scrolling down here. I have made, well, let me just go back and show you here. I have a scorecard already, an MBSIMP scorecard already created for this report. I have a PAS scorecard created for this report. I had some of those notes I was talking about. So with that, let's go back up and open this back up, and you can see when I create a scorecard, it will automatically pop it in here for you. So there's my MBSIMP scorecard, my PAS. Here's some of the series notes that I took. Actually, let me refresh this because it doesn't have my measurement tables in there. Let's go back down. So here are the notes I took for each series, along with the tables that I created as well. And I think some of my funny pasting is showing up here. Sorry, it looks a little messy in this one. Any of the snapshots are automatically populating in here as well. And I had those already in the study. I didn't do them while we were here, but I did add in this last compare snapshot. So basically, the report template just says, put any snapshots you make into this place, put any compare snapshots that you make into this area, any scorecards you create. So the template will contain all that, so you don't have to go back and paste all that stuff in later. So you open it up and you're well on your way. Some of the other things that we've enhanced within the reporting feature itself is now I have these little drop-down menus. And anybody that's used to using Epic as an EMR will be familiar with this. But we used to have the menu here was like all of the selections in this big yellow blob. So now it's contained underneath a title that you can give it. So I've called this Select Voice. And when I click on it, well, here's my pain scale, and select my voice. So you can, and when you make a selection, it automatically jumps you to the next data entry point. So if I can type in my intake status here, and if I hit F2, it automatically takes me to the next free text field, F2, right to the next one again. And again, here are my scorecards that I had. One of the other things we just changed the ability to do are the tables. We've had tables in here, but they've always had borders around them. Like so, you can now make tables without borders. It's like Doctors Without Borders, except it's a table. So there's the, and these, you might find different ways of using these. Here I was just putting sort of a, a therapy plan for maybe a patient. If I could have a patient report, because reports you could have multiples of, and you could pull one out and print it out for the patient right there if that was something you wanted to do. So those are the new features within reporting, and really sort of all the new sort of customer facing features that you would see outright. There's some that I can't really show you very well here, but we do have some new functions for types of, depending on different endoscopes that you might be using, the ability to change like black level in the scope, or flip an image upside down, or mirror it sideways, left to right. So those are our options, because sometimes if you hold a scope a certain way, now the image is upside down, and you may want us to be recording it flipped, flipped over. So we can totally do that. We have a new feature called TIMS Send. So if you're recording in your fluoro room or recording on your fees cart, and you send to your TIMS review back in the office, TIMS Send leaves the file in a more native format that we use, and it increases the send times. We're finding it's 2 to 10 times faster than converting it to DICOM, which we were doing before, and then sending it off to your TIMS system. So if you're a busy hospital and doing a lot of studies throughout the day, these sends will go much more quickly, so you can free up a fees card for another patient that's waiting, or free up a fluoro room for another patient that's rolling in right behind the one that's leaving. So we're always looking for ways to save you some time. We are also added the support for ORL video scopes too. So another brand of fee scopes that we've had a number of people asking for support for. So with that, what did I miss, Brooke?
We have a couple of questions in the chat, and then if anyone wants to unmute or take your video or turn your video on and come and hang out with us, feel free to. But one of the questions that I want to answer first, because I'm assuming a lot of people have this question, because I know I've answered it a few times, is specifically about bolus measurements. So the question is about using the freehand tool and how best to measure bolus percentages, specifically when your fluoro image quality isn't as pristine as the one you demonstrated, which we always get a question about that. That image is from a Shimatsu, and I will also say that my fluoro equipment at my hospitals is not as clear either. So I've had the same exact problem with our challenge in terms of measuring bolus percentages. So the question is, what is the best way to measure I'm gonna actually read it. It says, I use the freehand tool to measure residue on video fluoroscopy. The magic brush doesn't work well because our image quality is not as clear. So that first point I do want to address really quickly. If you're not on MVP 5.0 or now 5.1, definitely make sure you're on the most up-to-date software, because this question came up at one of our previous webinars that people were having trouble with the magic brush and the magic wand because their fluoro image quality wasn't as clear. So if you were having that problem when you're trying to use the tools that Tim demonstrated, basically the line just kind of broke apart and captured a lot of unnecessary imagery. So our engineering team actually watched the webinar and updated those tools to help address that problem. They just had been using this Shimatsu imagery, which is obviously really clear. So if you haven't updated your software, make sure to do so, because that might actually help address that. But then in terms of using the freehand tool, again, in the demonstration that I did with the screenshots, as you all can relate, in clinical practice, a lot of times the residue isn't cohesive. Maybe there's some in the oral cavity and some in the pharynx. So in that case, I do recommend using the freehand tool, which our engineering team, they did update it, again, based off of that previous webinar to be more similar to the freehand tool in ImageJ, where it snaps to close. So if you haven't updated your software, I definitely recommend doing that. But in terms of other recommendations, I know Tim and I have spoken with our engineering team to potentially update the freehand tool in future versions of TIMS to have an even more thin line, which we think should help us, outline residue that's even smaller than what we're currently able to do. So Tim, I don't know if you have anything else that you would add to that. The rest of her question was, I noticed that depending on how spread out the bolus is in the pharynx, it impacts how the residue is measured and impacts the percentage reported. I try to measure when the bolus is the most cohesive based on past TIMS presentations, but is there a better way to measure? So,
Yeah, no, I think you covered it pretty well. And again, I think some of these we're trying to help make things a little more precise than just looking at it and guesstimating like percent residue and things like that. And, now you can get pretty darn close to what the actual value is. But we're, constantly refining and taking feedback from the field. So we love to hear from you guys. If there's something that, is working well or not working so well, please drop us a line. You can send it to info@tims.com is a really good place, because both myself and our VP of Sales and Marketing see that, and we can get that off to engineering. So that's a good spot to do it.
Amy's question was, is there a way to transfer the report to the EMR? We use Cerner. So to answer Amy's question, and anyone else that's interested in that report integration into your EMR, it's really specific on your hospital's requirements. So you'd want to get with our support team to get that set up. But yes, we can definitely help you get that set up to help save you time, like we demonstrated in this presentation this evening. Tim, I don't know if you have any details you'd like to add specifically about.
There's basically three ways that no matter what EMR you're using, or it is somewhat EMR dependent, but we have three ways of getting the reports there. You can save the report as it's completed. It'll save it as a PDF file with the study and send it to your PACS or VNA. So it's a PDF that's attached with the imagery, and it all goes to your PACS VNA. And a lot of EMRs can see that PDF there and pull it into a specific location within, when somebody opens the patient record, it'll populate into there so that the report becomes automatically available. So that's one way to do it. And that's a really nice, simple way to do it. You just do a report, hit send study, and you're done. The other way to do it is to export the PDF as a PDF to your desktop. And then many EMRs will allow you to, import a file or upload a file to the EMR. So you can do that as well. Another way that works very well with Epic, which, a lot of folks are using, is there's a command to just copy the report, and then you can paste it into an Epic Notes field, and it will retain all of that formatting that you saw in the report that I pulled up a little while ago, and it looks just like the report we were looking at. So that's a fantastic way to do it, and they look fantastic.
There's a question about manually importing fees into TIMS review and what file type or format they need to be in to do that.
Well, I guess I'm just curious if they don't have a network available to them, so you're not able to do, typically you would send the study after reporting it from your fees cards to a TIMS review software sitting on a desktop somewhere. But you can also export completed studies as a a DICOM file, and then it can be manually. TIMS review will see that, and you can, save it to like a USB drive, or to a network location somewhere, and those can be imported manually that way. But certainly the best way to do it is to, again, work with our support team, and they can create that network connection between the two to be able to send right from your fees cart or floor room to TIMS review.
So I think we got all the questions, but if anyone else has a question, feel free to pop it in the chat or ask it out loud. And then there was a question, or there was a couple of questions about kinematic analysis that will be covered in some of our upcoming meetings. So we'll be sending out emails about those, but you can also find updates on what we're doing here in the TIMS user group in our Facebook group. So I'll make sure to include the link to that in our follow-up emails. And of course, we'll be posting about all of these things on social media. So with that,
I do see one more. Actually, there's one more thing. I do see somebody's question. They're asking about does the software take place on the TIMS MVP unit or on the TIMS review, or both? And it is on both. So version 5.1 is an upgrade for both your TIMS system that does the recording and your TIMS review software. And again, just if you want to contact our support department, so that's support@tims.com. You can email them, you can call our main phone number, and it will guide you to our support department as well. And they will be very happy to set up a time to work with you and your IT department or biomed guys if you need it to do the updates on both those, both TIMS MVP and TIMS review. So we're really excited to get this out to as many people as we can.
Awesome. Thanks, Tim. And thanks everyone for being with us this evening. It was great to connect with you all. If you have any questions, feel free to email us or contact us at any of the platforms that we said this evening. And then if you're wanting ASHA CEUs, just make sure that you fill out that survey, and it'll be open from this evening until next Wednesday. So with that, we thank you for being here and hope you have a great evening.
Thanks, everybody. Have a great night. Take care.